Malignant hyperthermia that is untreated can cause cardiac arrest, kidney and liver failure, internal hemorrhage, abnormal blood coagulation, cardiovascular failure, neurological damage, and possibly death. Research suggests that malignant hyperthermia can be treated without a deadly outcome by identifying patient information to help recognize the risk of an MH event and triggers that could cause the MH event. My main points of this presentation include MH could be prevented by knowing the patient's medical history prior to surgery, such as the antiseptic records, labs, and genetics, and also how to recognize the triggers of malignant hyperthermia and how to prevent death once MH crisis occurs. Knowing the patient's medical history prior to surgery could possibly help prevent MH. According to Kane, MH can transpire in females or males, but is most common in males. Patients at risk of MH often have inherited skeletal muscle anomalies and some muscular dystrophies. MH can also occur as a consequence of the defect RYR1, which originates in all skeletal muscle and is accountable for calcium release, according to Kane. Family members such as children or siblings of a patient with MH susceptibility have a 50% chance of inheriting a gene defect for MH and becoming MH susceptible. The inherited gene defect that is manifested by the carriers for MH may not be known of the risk of MH if they do not have a family member that has not already developed the crisis during an anesthesia. If a patient experiences testing for known genes and has a negative result, it does not mean that the patient is not MH predisposed, according to Seifert. Lack of a positive genetic test does not equal the lack of predisposition, and also not every person who is a carrier undergoes an MH crisis or an involvement to the triggering antiseptics. If there is thought that the patient could be at risk for a triggering agent, there are other antiseptics such as an epidural, spinal, regional, or local anesthesia, according to Stratman. How do we recognize the triggers of malignant hyperthermia and prevent death of an MH crisis? MH is a hypermetabolic state taking place in skeletal muscle cells, which is often caused by administration of often used general antiseptics such as sevoflurane, enflurane, halothane, desflurane, or isoflurane, without or in combination with succinylcholine, a depolarizing muscle relaxant, and neuromuscular blocker. According to Seifert, heat, stroke, trauma, vigorous exercise, or emotional anxiety can cause an MH crisis. Symptoms of MH consist of hypercarbia, which is an increase in carbon dioxide, hypoxia, which is a decrease in oxygen saturation, metabolic and respiratory acidosis, tachyapnea, which is an increase in breathing respirations caused by CO2 production, dysrhythmia such as premature ventricular contractions, and a rise in body temperature. In North America, a study analysis of NH cases from 1987 to 2006 revealed that many initial symptoms of NH were sinus tachycardia, hypercarbadia, or masseter spasm, and temperature irregularities being the first to third sign of an MH crisis, according to Kane. Stopping the abnormal metabolic process, which with dantrolene is the purpose of a treatment in MH crisis, and to return to regular temperatures, hemodynamics conditions, and metabolic functions. A prompt, targeted, and effective coordinated response by all surgical team members is necessary to achieve these goals and prevent the potential lethal consequences of MH. My visual shows here the crisis considerations to malignant hyperthermia. Here are the steps one might take in proceeding through the protocol. The first step in an MH crisis occurring is review patient safety and call for help if needed. In the event that a patient is undergoing an MH crisis, medical staff must react fast and identify the steps needed for a life-saving outcome. First, a patient assessment needs to be done preoperatively. The assessment is done by obtaining previous surgical antiseptic records for documented episodes of MH, temperature, anomalies, or unusual reactions to MH-associated antiseptics. All they find out if they have any family members have experienced an MH event before, check lab results, check inherited metabolic anomalies, and planned use of an antiseptic triggering agent. Next, what is the management plan and who will direct the crisis? Surgeons, surgical assistants, anesthesia, professional, or RN circulator. In an MH crisis occurring, one will need to call for help. This will be when the MH cart needs to be available for use. Thirdly, what is the management plan? Who will direct the crisis? This can be performed by any member of the surgical team, such as the surgeon, which can stop the procedure if able, anesthesia professional, whom can ask for MH medications and stop volatile inhaled antiseptics, an RN circulator who can call for help, or surgical scrub who can be ready to assist with lavaging any body cavities. And lastly, it is time for the surgical team to initiate the MH protocol. The protocol consists of cooling the patient by lavaging exposed body cavities, administering dantrolene, and switching to a non-triggering antiseptic if probable. Correct metabolic acidosis, correct and treat hyperkalemia, correct dysrhythmias while excluding calcium channel blockers, and assembling additional medical workers. This visual is from Siegfried, Lohr, Pace, Cochran, and Bagnall. In conclusion, identifying the patient's health and family history and recognizing perioperative triggers could cause a malignant hyperthermia event, prevention, and future MH crisis events and deaths of our patients. Extensive health and family needs to be done on patient history of MH. Thank you.